Earlier in the year, one of the two private hospitals that I work out of did a video on a few consultants, and they did one of me discussing bunion surgery. They've just uploaded it today, so I've copied it to my webpage here. Coincidentally, I just did a video on Monday of a surgery of a bunion, so I'm going to work on the edit of that video and I'll try and post that next week. A bunion is a dislocation. So instead of the toe being somewhat straight, it comes off at a bit of a jaunty angle, so the metatarsal comes out to the side and then the toe falls in towards the midline of the foot. The main cause of bunions, I think, is the way you walk. So flat-footedness, hyperpronation. So if you spend too much time rolling on the inside of your foot, you overload the big toe, and with years that can dislocate. So I absolutely think that bunions will be made worse by shoes. So if you are wearing a shoe that's pointy, a bit of a court shoe, stiletto, and you're pushing the big toe across, then for my money that's going to speed up the progression of a bunion. If you've got a wide foot and that's the foot splaying out, if you then wear a shoe that's too tight, you'll certainly make those symptoms worse quicker. So some of the patients I see, their primary problem is medial bump pain. So if you then wear shoes that actually fit the foot, you can keep the symptoms down. That's not going to stop the bunion developing, but you might be able to deal with the symptoms if you wear sensible shoes. If you can really jack somebody up with an insole, I think you can, again, really help with the pain and maybe slow the progression over time. And as well, you can get bunion splints as well, and they sell them as bunion correctors. They don't correct the bunion, but I think they can help with pain. When your symptoms become unmanageable and you want to see, and it might be that first port of call is your GP or a podiatrist or a physio, and so pain is going to be the main thing, followed by issues with footwear. So if you're not able to wear the range of shoes that you want, that's the time to maybe sing out. Now, I'm not going to rush you down a surgical route very quickly. I'm quite cautious in terms of wanting to take somebody to theatre. There'll be times we'll say now's the time for surgery, but it's always the patient's decision. You can always avoid surgery. Absolutely, it's always going to be down to the patient who wants the surgery, and the surgeon must think that that's the best thing for the patient. However, there'll be a point for, I operated on 3 today, so my 3 ladies out of my 4 that I operated on today, they all had pain that was beyond the level they wanted to live with, and there's a very good chance that all those patients will be pain-free by the end of the year. If your problem is mostly medial bump pain, if you want to wear shoes that accommodate, so I've got lots of ladies of a certain age wearing Crocs as their primary style of shoe. I like Crocs. Now that might not be the type of shoe that you want to wear, but if you want to avoid surgery and you're going to say, okay, well, I'm going to wear Crocs and medial bunion splints and I'll look a bit frumpy and that's fine, then you can put surgery off for a long time. Surgery is not painful because you can have an anaesthetic and you can be awake or asleep. So my first lady this morning elected for regional block. She didn't want to be asleep, so that's fine, we can do that. And then the other 2 ladies were asleep for surgery. And while the patients are asleep, we put in local anaesthesia so they wake up pain-free. And then what we do is we manage them really quite aggressively with oral tablets for the first 2 to 3 days. That's the worst period of pain, and things will then get better quite quickly. So in truth, 1 or 2 patients will have a degree of discomfort. Most will do fine, and some patients will have virtually no pain at all. But we work really hard between local and general anaesthesia and tablets to make it as comfortable a process as we can. So some operations are more stable than others, so all the patients that I operate on today, they can walk on it straight away. Rule of thumb for those is 2 days bed rest, so really keep off it for the first couple of days. And they'll be hitting painkillers quite hard for the first 2 days. And then it's 4 weeks light duties, sometimes 4 to 6, depending on what particular procedure that I do. Typically, patients are back driving at week 6 and back to a good level of activity by about month 2, month 3. Again, depends on the procedure, and it depends on the patient as well.